Some notes for diagnosis of ventilator-associated pneumonia. It is suggested by new or progressive chest X-ray infiltrates in association with fever, high inflammatory markers, purulent secretions, and worsening of ventilatory parameters, such as increasing respiratory rate, decreasing tidal volumes, increasing oxygen requirements. There are many non-infectious causes of fever and chest X-ray infiltrate in ICU patients, so the diagnosis is not always straightforward. We should consider other common sources of fever in ventilated patients, such as infected IV casters, urinary infections, C. difficile colitis. Investigations for diagnosis of ventilator-associated pneumonia include chest X-ray, which often shows a non-specific infiltrates, with air bronchogram being the best predictor of the disease, airway sampling for microbiology by bronchoscopic sampling, protected specimen brush samples with the tip of the bronchoscope placed opposite the orifice of the involved segmental bronchus, and protected specimen brush advanced through its protected sheath into the airway, or bronchoalveolar lavage samples from a subsegmental bronchus with the end of the bronchoscopic wedged into the airway are the optimal methods to obtain lower airway samples with minimal contamination. The VAP is diagnosed when an arbitrary threshold of organisms is grown on BAL or protected specimen brush sample. Usual cutoff are 1,000 colony forming units per ml for protected specimen brush samples and 10,000 cut off or colony forming units per milli for bronchoalveolar lavage samples. Their threshold vary between units as do threshold for starting treatment. Non-bronchoscopic airway sampling, such as blind bronchial sampling of the lower respiratory tract secretions, which sometimes called mini BAL or mini bronchoalveolar lavage, is cheaper and does not need an expert operator. A catheter is advanced through the intratracheal tube until there is resistance, and saline 20 ml is infused and then aspirated. Serial sampling is favored in some units. Regular non-invasive serial airway sampling may aid early diagnosis of ventilator-associated pneumonia, requires careful interpretation as microbiology of the respiratory tract changes over time in critically ill mechanically ventilated patients. Tracheal aspiration samples are easy to obtain but non-specific in diagnosing ventilator-associated pneumonia, as upper airway colonization is common.